The topic of medical child abuse came about as a result of a request from our professional practice group, and many of you will be familiar with Lorraine and with Michelle from that group. We were particularly interested in the links between medical child abuse and social work practice, and went out and commissioned Allen and Clark to do the review for us. In particular, Jacinta Cording held the keyboard on this piece of work, and it was a very rapid piece of work. We moved from commissioning to having an end product in 3 weeks, so that's pretty fast for doing this type of thing. We focused on articles from 2010 onwards, but included research from before then if it seemed significant, and we searched both for international and New Zealand-based research. We had multiple uses. We wanted to know what the current understanding of the topic was. So medical child abuse, also known as factitious disorder imposed upon another, or resulting from factitious disorder imposed on another. And some of you will be familiar with the name of Munchausen syndrome by proxy. It had multiple intended uses to learn of our current understanding of the topic, to share with our workers, social workers, and to inform professional practice here in Oranga Tamariki, and to look towards the future. The focus was on harm to children rather than the much broader picture. And 44 articles which were relevant and in the time period of particular interest were focused on. What we found, though, was that there was gaps in the literature. There was very little that was actually directly relevant or to whānau Māori, particularly, or other Indigenous populations. What I learned from this research activity was reports of medical child abuse in New Zealand are rare, and also it's rare internationally. It's probably underreported, and identification can be difficult. Consequences are often severe and long-lasting for the child, but also for their family. The person who imposes the harm is often the mother, and social work focus is on the safety of the children. So that's a very brief romp through our literature review. That review is available on the Oranga Tamariki website under the research area. So if you want the full story, that's where you'll find it. Dr. Patrick Kelly, over to you.
Got three objectives really for, I think, what I've got in the next 15 to 20 minutes. One is to talk about what's in a name. Secondly, hope to give you some appreciation of the complexities of this form of abuse. And probably thirdly and most practically talk about an approach towards it. But firstly, what's in a name? Many people are familiar with the term Munchausen syndrome by proxy, and that originated in an article published by a paediatrician, Roy Meadows, in The Lancet in 1977. And I just have put his summary of the two cases he reported up on the screen, so you get some idea of the scope and complexity of the way these children present. So first,
to re-share your presentation, we can only see your face.
Oh, really? Okay.
No, I can see it.
I can see it.
I can see it.
I can too.
So can I.
I can see it too.
And I can see it.
Yep,
You're
very
good,
clear,
Patrick.
very clear for me. All good, Patrick.
I think most participants can, but perhaps if you can't, let us know.
So the first case was a child where over a period of 6 years, and it uses the word the parents, but as Velma has already alluded to, it was actually primarily the mother, systematically provided fabricated information about their child's symptoms, tampered with urine specimens to produce false results, interfered with hospital observations, So the child had innumerable investigations and anaesthetic, surgical and radiological procedures in 3 different centres. And many cases will be very similar to that, and it's complicated in every country in the world by the fact that these children often tend to move from one centre to another, not necessarily in terms of their residence, but they may well be referred from one specialist to another, because what tends to happen is, because these cases are seen as very complex or insoluble, they tend to graduate up the medical hierarchy, and you end up therefore having more and more health professionals involved, which is one of the complexities. The second was a child whose mother was essentially poisoning the child with salt, and again the child presented in multiple different centres and eventually died.
Wow.
Now he termed this Munchausen syndrome by proxy, and the reason he did that, well, hopefully I can move to the next, was for this famous fictional novel with the adventure of Baron Munchausen, which was essentially an 18th century raconteur's novel about this bizarre guy doing bizarre things. And the reason he chose the term was that there was an adult psychiatric condition recognised called the Munchausen syndrome, in which adults would fabricate or induce symptoms in themselves, presumably in order to gain some benefit to themselves from being engaged in medical therapy. Now, there are all sorts of complex psychological reasons for that, but Roy Meadows was applying the condition to children who suffered harm as a result of health-seeking behaviour on behalf of their parents. And he actually intended the diagnosis to be made in a child, not in the parent. It was about the harm caused to the child rather than the motivation of the parent. And in some ways, the name Munchausen syndrome by proxy has become something of a curse, because what it does is make people focus so much on the bizarre motivation of the perpetrator that sometimes they lose sight on what's happened to the child. So that's why the terminology that certainly we prefer at Starship is medical child abuse, which is terminology proposed by Tom Roessler and Carol Jenny in 2008. Now, Tom Roessler is a child and adolescent psychiatrist, and Carol Jenny is a paediatrician, probably the world's leading paediatrician in the area of child abuse and neglect. And they described a large case series of close to 200 children that they dealt with in their hospital in Rhode Island, where they actually had established a treatment centre where they would work with families, either with or without child protection services, depending on the severity of the condition, to try and fix this problem. And their definition was medical child abuse occurs when a child receives unnecessary and harmful or potentially harmful medical care at the insistence of a caregiver. And they stated, and I agree with them absolutely, that we prefer the term medical child abuse because it focuses on the potential or real harm being done to the child regardless of the perpetrator's motivation. So if you want to think of the health system on the left, doctors and nurses and hospitals in a medical setting, and the hammer on the right is a fairly blunt way of pointing out that essentially in medical child abuse, the health system becomes the instrument by which a perpetrator hurts a child. And that is the key issue here, that a perpetrator, typically the mother, is hurting a child, often in very severe and prolonged and emotionally harmful and physically harmful ways. And the medical system is simply a tool in the hand of that parent or caregiver. Now, it's fascinating to try and understand why the caregiver is using the medical system in that way. And certainly many of those caregivers may be motivated by the same thing that drove Munchausen syndrome in adults. That is, they get their psychological kicks out of the kind of attention and focus that they receive from being the centre of attention in a healthcare setting. Now, that may be the motivation for many perpetrators, and that's why factitious disorder imposed on another is in the DSM-5 as a psychological disorder in adults. And if you look at Valmai's literature review, much of it focuses on factitious disorder imposed on another, the psychological criteria that you use to diagnose that in an adult. But I'd really want to remind you that it is primarily a diagnosis made in a child, but this is about the harm that a child is suffering. And there will be a subset of those adults, a large subset perhaps, who are inspired by the desire, the benefits they get from being engaged in healthcare. But it's often much more complex than that. And in fact, there is no specific psychological profile that fits the adults in this case. So one of the questions, of course, if you're working in healthcare is where do you cross the line from the normal range of health-seeking behaviour to what becomes medical child abuse? And one way to conceive about this is that when you think about healthcare behaviour, there's a whole range from, on the left-hand side here, numbered as 1, people who will never go to the doctor, whether for themselves or for their children. And in children where parents never go to the doctor, some of those children will eventually suffer harm, and some of them will suffer neglect of medical care, and they'll come to Oranga Tamariki. And we already have an interagency guideline for that group of children. And in some ways, you can consider medical child abuse as at the far end of the spectrum on the right, where you have children who are now coming to harm not because their parents are avoiding medical care, but because their parents are insisting on inappropriate and harmful medical care. And when does an anxious or hypochondriacal parent who takes their child to the doctor unnecessarily, when do they cross the line to a child who, a perpetrator or a parent who is causing medical child abuse? And essentially they cross the line, of course, when the child begins to suffer harm. Now, the unfortunate problem with defining that line is that many children with real medical conditions will suffer a degree of harm from the investigations and the treatments that they receive. If you think of a child who is suffering from leukemia, in order to save their life, you have to put them through a series of processes, blood tests, painful procedures, chemotherapy, radiotherapy. Their hair will fall out, they'll spend months in hospital, they'll drop out of school, they suffer enormous harm, but the benefit is that in the end their disease will be cured and they go on to live a normal life. The problem in medical child abuse is that a child who does not have that condition is being subjected to the same harm, and the reason they're being subjected to that harm is because the parent is either lying about their symptoms or in fact causing them to have symptoms. Now, it's very hard in a 20 minutes or in a literature review to give you the flavour of what this is like, but I think it's important that you get a child's perspective on this. And this is a paper published in Pediatrics in 1997, which was co-written by a woman who had experienced medical child abuse all her childhood. And when she grew up, she co-wrote this article with a psychiatrist, and they reviewed her notes from her childhood together. Now, she spent many years in and out of orthopedic wards with recurrent infection. What the doctors did not know was that not only was her mother breaking her leg with a hammer, when she went home and her mother, who was a nurse, was providing her care, she would lift the plaster and contaminate the wounds with soil. So she actually was repeatedly reinfecting her child so that her wounds never healed. Now, whatever the motivation of this mother was, the key issue here is that this was clear and repeated and persistent physical abuse. You don't need to know the motivation of the mother to know that she was causing her child harm. And this was a case of mine that I can mention here, of course, because it went to court. Some people in Auckland will be familiar with this case, and this involved 2 children. The older child spent 4 years going through the medical system in 3 different DHBs for several different conditions that she did not have. This included being dosed with anti-epileptic medication that she didn't need, being treated for juvenile rheumatoid arthritis that she did not have, undergoing many procedures and surgeries and investigations. And then finally, when the woman had her next child, what only brought this all to an end was when she attempted to suffocate this child and videoed the child in their cyanotic apneic state. So whatever her motivation was, it was very clear that both of these children suffered an enormous degree of harm. And those of you who follow the news or TV programs may well have heard of this story of a woman who eventually, with the assistance of her boyfriend, murdered her own mother. And it was only after she went on trial for murder that it was revealed that her own mother had subjected her to medical child abuse extensively throughout her childhood, such that at the time that she murdered her mother, she was believed to be confined to a wheelchair and profoundly intellectually disabled, and in fact, neither of those things were true. And one of the tragedies of this story is that the young woman herself, who you can see on the right as an adult, said that she felt freer in her prison, where she was sentenced to 10 years for her role in the murder of her mother. She felt freer in prison than she had ever felt in her own home as a child. Now, one of the reasons I mention that is because if you go to that web page, you'll read this. Experts believe that Dee Dee's behaviour stemmed from the mental disorder Munchausen syndrome by proxy. Because Dee Dee wanted to be a caretaker, she feigned and induced illness in her daughter. It's a very common mistake because, of course, Roy Meadow used the word Munchausen syndrome by proxy not for the perpetrator, but for the child. And what my experience is that often in these cases over the years, often at the point of referral to Oranga Tamariki, people become obsessed with the question is, does the mother have Munchausen syndrome by proxy? That's really not the question. And even if you use it in the terminology of the current DSM-5, does the mother have factitious disorder imposed on another? Again, that's really not the question. Understanding the psychological motivations of the perpetrator are important if you're thinking long-term about safety and the possibilities for therapy and reunification, but they're not important in coming to a conclusion that a child has been harmed and that action needs to be taken to keep them safe. And the reason why I mention this is I've had people say to me in case conferences, you've diagnosed Munchausen syndrome by proxy in the mother, and I've done no such thing. So steps to diagnosis for healthcare professionals. One of the key things I think about this condition is that it is a complex interaction between healthcare professionals who are trained to believe parents and to always go looking for answers, and perpetrators who are manipulating that way of thinking to the harm of their child. Now, how am I going for time, Valmai?
I think we have another minute.
Another 10 minutes?
Yeah.
Okay, cool. So Dania Glaser, who's a child and adolescent psychiatrist in the UK, has suggested, I think, quite a helpful way forward for health professionals. And that is that we need to be much better at recognising and identifying what she calls perplexing presentations. And if you go back to Roy Meadow's original article in 1977, one of his phrases has always stuck out for me. The problem seemed insoluble and many of the facts did not make sense. Now, one other aspect of my practice is, of course, physical child abuse in general, and I've long learned that one of the key issues in physical child abuse is, does this make sense? And the same thing applies in children who are presenting with increasingly complex medical conditions that don't respond in the normal way to the normal treatments, that have symptoms that no one ever seems to see except the mother, that don't behave in the way that those diseases should behave. So when a doctor begins to recognise that this problem is beginning not to make sense, you can't assume that it's Munchausen's or medical child abuse, but you do have to take an extra degree of care to be sure that you understand what's happening. And one of those things is documenting in meticulous detail and including taking steps which health professionals don't necessarily always take to corroborate the story. And the obvious example would be a child who presents with the mother reporting that the child is having seizures at school or at preschool. The obvious thing for a doctor to do is to be ringing the preschool and talking to the teacher and seeing if others have witnessed those seizures. The other thing that many of these children tend to do is their parents often engage them with multiple healthcare providers, and it's important if you're seeing these children for a healthcare provider to get in touch with all those others. And if there's a point where you're seriously beginning to be concerned that this really isn't making sense and you're worried that symptoms are being fabricated or induced, then all the health professionals involved need together and reach a consensus about what is happening here. Do they still think this child has an underlying medical condition or do they not? And often when you get to that kind of meeting, in my experience, certainly at Starship, you'll sit around a table with 6 other subspecialist paediatricians and none of them actually think this child has the condition that the mother is pushing them to diagnose, but none of them have quite been able to reach a threshold to express that concern to others. And often the professionals meeting is the first opportunity that finally everybody says, yes, we're all on the same page here, and then you have to identify a way forward. And Glaser suggests a proposal something like this, and I've put it in green, orange and red, partly because it correlates with the traffic light approach that's present in the neglect of medical care guideline. And ideally going forward, I could see a situation where we had another schedule under the Memorandum of Understanding between police, DHBs and Oranga Tamariki, where we adopt this approach. A traffic light approach is when you're in the green zone, the health professionals are in the situation where it's beginning not to make sense, but there are still investigations to be done. There are some health professionals who believe this child still may have epilepsy. This child needs perhaps to have other EEGs, other investigations which may not cause harm and need to be done. But there needs to be a coordinated plan. There needs to be someone taking a lead role and trying to ensure that this child doesn't go off to see multiple different professionals to ask the same question. And there needs to be a family meeting where there's an honest conversation with the parents about the diagnostic possibilities in terms of health conditions and the way forward. Scenario 2 really is where you've run to the end of medically justified investigations. You've still not got any concern that the child is necessarily coming to harm, but you believe they will come to harm if you carry on down this pathway of unnecessary investigation. So there has to be a halt call to investigations, operations and surgery, and one needs to hold what some have called a good news meeting with the family. Here's the good news: your child does not have this condition, that condition, or the other condition. We need to focus now on a rehabilitation approach, on getting your child back to school, on limiting the number of investigations, etc., etc. And in Ressler and Jenny's rehabilitation centre in Rhode Island, they were able to work successfully with a number of families if they could put a stop to this potentially harmful health-seeking behaviour and reorientate the family to a different way of dealing with the child's symptoms. But if the family aren't responsive to that approach, or if it's too dangerous to do that approach because the child is already coming to harm, then you may have to go into a much more assertive scenario 3, which is a child protection process. And when I say too dangerous, I mean one of the classically dangerous situations in medical child abuse is particularly suffocation, where a mother who is suffocating her infant and is beginning to sense that the health professionals are becoming sceptical about the diagnosis may suffocate the child more vigorously even in the hospital in order to prove that the child has an underlying medical condition. And if you're afraid that the outcome of involving Oranga Tamariki is going to be that something like that may happen, you obviously need to have your consultations with Oranga Tamariki about what you're going to do next before you confront the parents about your concern. So whether it's acutely for a situation like that or whether it's in a more planned fashion, for example, a child where the parents really will not accept the health professional's conclusion that the child does not have these diseases, and they're going to go off to other health professionals, they're going to go on and do further unnecessary tests and investigations, and those things are going to cause harm to the child, then the health professionals really need to reach a consensus that none of those conditions exist. They need to make that very clear in their documentation, and they need obviously to involve Oranga Tamariki. Now I've put here a report of concern, but in fact it's not simply a report of concern. And in many ways this is analogous to the neglect of medical care guideline. Often by the time you get to the point of involving Oranga Tamariki, this history may have gone on for years. It's complex. It involves a whole lot of medical information. You'd have to just about get your head around an encyclopedia of medical science to understand everything that this child may have experienced. So it's really incumbent on the health professionals to make sure they have got their head around all those years of information, that they've synthesized them, they've made them comprehensible, they've made it clear, and they've reached a clear combined decision that this child does not have any of those conditions. If you get 6 professionals around a table and one subspecialist says, I still think this child has condition X or condition Y, it becomes very difficult to take the matter forward. And I think so from my perspective, in a case like this, as for neglect, what we should be doing is, yes, making a report of concern, but often preceding it by a multi-agency meeting with someone senior from the site involved, explaining the situation and thinking about the plan forward and deciding, is a report of concern the appropriate thing to make? If it is, what kind of information do you require? And those meetings, I think, should be resulting in multi-agency safety plans and very detailed multi-agency plans for how we go forward. Because one of the key characteristics of the mother, particularly in these cases, in my experience, is that they're very, very good at eliciting sympathy. They're very, very good at presenting themselves almost as saintly figures who will never leave their child's side. They're very, very good at splitting between professionals. You see it all the time within the health system where they will play off one health professional against another. And I've also seen it in interagency practice where they will play off the health professional against the social worker. So it's very important that we work really hard at good information sharing and good, tight planning. Now, once hopefully we've secured the safety of the child, then assessment of the mental health of the perpetrator obviously is important, and that includes an assessment for factitious disorder imposed on another. But I just want to re-emphasize that understanding the psychological motivation of the perpetrator is not the primary driver here. There is no form of child abuse where you only diagnose it once you understand why the perpetrator did it. It's not true of child sexual abuse, it's not true of child physical abuse, and it's not true of medical child abuse either. So in summary, I think we need to identify it, and in many ways that's because of the way this condition interacts with the health system. It's the health professionals who have to identify it and be willing to stop it. If the family can't be diverted into a better way of interacting with the health system, then it is going to become a child protection issue. And that's where Oranga Tamariki are profoundly important in terms of providing ongoing safety. But we also need to think about repairing the damage. And I've dealt with a number of children over the years who have lived for years in an environment where they have been told that they are dreadfully, perhaps terminally sick, where they've been said that they're going to have parts of their bowel removed or they're going to need to be in a wheelchair for life. One of our recent cases, by the time she was diagnosed, had a tracheostomy, which is a breathing tube into her throat, a gastrostomy, which is a feeding tube into her stomach. She was wheelchair bound and she had multiple neurosurgical procedures. Making this diagnosis and keeping her safe resulted in the transformation of her life, but nonetheless she still had something like 13 years of this background that she has to process into the future. So that's just a very brief summary of the complexity of these issues from a paediatrician's perspective.